Well, hi, and welcome to Habitual Excellence. I'm Mark Graban from Value Capture, and we have two guests today joining us from Duke University Health System. They are Dr. John Anderson. He is the Chief Medical Officer for Duke Primary Care within the system. And we're joined also by Elizabeth Long, the Chief Operating Officer. So John and Liz, thank you both for being here. How are you?
We're great. Thank you, Mark. Thank you for having us on the show.
Doing very well, Mark. Thank you.
Well, good. So I'd like to hear, I think the audience would like to hear a little bit about your backgrounds, and then we'll talk about the improvement work that you're doing and how your leadership roles, how the two of you are working together. But I was wondering if you could share a little bit more about your professional backgrounds. Liz, maybe starting with you first.
Sure. So I have the pleasure of serving as the Chief Operating Officer of Duke Primary Care and Duke Urgent Care. We're a network now of about 400 providers in multiple sites around the Triangle area, the Raleigh-Durham area. I've devoted the better part of my professional life to physician practice management and network development, so largely focusing on strategic operations management, development of the network. Prior to that, worked for the faculty practice plan for about 13 years at Stanford Medical Center. So have been with physician practice my entire life. So,
And mostly in academic medicine settings, from West Coast to almost all the way to the East Coast. And John, can you share a little bit about your background and career?
Sure. Thank you, Mark. So I am a family medicine trained physician, have been in North Carolina since 1983 when I finished my training. Became part of the Duke Health System in 95 when Duke Primary Care was created. Duke's response to the managed care movement of the 90s, and have been in this role as Chief Medical Officer for about 20 years as the network has grown over the years. I still have the opportunity to see patients, but have enjoyed creating the culture and leading this organization over the years with a focus on quality and improvement and how we go about that work. So it's been a fun journey.
Yeah, and so it would be good to hear about that journey, the improvement journey, or however you would like to frame it there at Duke Primary Care. How did you get started? John, you mentioned quality as a key factor. I mean, I'd be curious to hear from one or both of you about some of the starting points.
Well, it's interesting. I can start off, and then Liz we can take turns telling this story, because I think it actually is a good story. And we started off a long time ago. I was working with some colleagues at a neighboring institution, and we were starting some of our quality work, and they looked at me and said, we go to this meeting every year, and it's a pretty fascinating meeting. I think you would like that. So they took me to my first IHI meeting back in the day when Don Berwick was leading that organization. And so over the years, we had worked with the IHI, adopted their model for improvement, used that approach when we were looking at the open access model, at chronic disease care, and used that for initially to get us started. And then that evolved to where it became clear that as we wanted to expand what we were doing, we had a transforming primary care collaborative that we felt like we needed to take a little bit different approach, and that's where we got into the lean work and began more of our lean journey. Liz can talk a little bit about that and fill in some of that gap.
Yes, it's so fun to me to think back to the early days when we started attending IHI. I remember a couple of Don Berwick's plenary speeches brought me to tears, and really an exciting time. And I credit Dr. Anderson. Where we really started was even before that, John, when you said we are not just a primary care network attached to an academic medical center that refers patients into the system, that we bring value and quality to our patients, and set that quality vision for us. You also inspired the network to think of itself as a group practice rather than an affiliation of individual practices, so that it allowed us to have a mindset, a collective mindset, to agree on goals and to work collaboratively to achieve those goals. So I don't think we can miss that foundation that you provided us, the leadership. And the access work that we did initially, leaning heavily on the teachings of Mark Murray, I'm really dating myself, we achieved some really impressive results. We had really a very challenged access back in the day, and wait times of 6 months for annual physicals, that sort of thing. But we used the learning collaborative model, as John said, the model for improvement, and we're able to achieve some really remarkable improvements in our access. Did you want to tell your access stories now or later?
No, we can save those for later.
And then, as John said, and we started using it's so funny to think back, we were using an Excel file for a disease registry, but we decided to apply for certification as a patient-centered medical home. And what that brought us to realize was that we needed standard work and standard processes. And so, as John said, that really got us starting down our lean journey. Additionally, at that time, we, as a system, converted to the Epic electronic record, which also drove home the need for standard workflows, processes. And so this concept of standard work has been with us for about 10 years or more. And we realized, though, after several years of being pretty solidly entrenched in standard work for our frontline staff and providers, that what we lacked was standard work for leadership. And that we didn't develop that, adopt it, that we weren't going to be able to achieve our goals, which sort of set us on the second stage of our journey, which we're still, it's always, you never complete the journey.
Sure. So you mentioned improving access to care. When thinking through some of the focus of why improve, I was wondering if you could explain, John, a little bit more about the quality vision. How do you define quality? How is that measured in a primary care setting, as opposed to, let's say, the hospital side, where Duke and other organizations have a public pronouncement to working towards zero harm? That might be more applicable on the acute inpatient care side of things. How does that differ in terms of the quality vision in primary care?
I think our focus was always grounded in the fact that we can do better. So we can provide better access. We can provide better blood pressure control. We can provide better well child care. It was traditionally, and still is to a large degree, about improvement and how do we, make fewer errors, get more patients to target. One of the things that's been interesting to see over certainly my career is we didn't have a lot of treatments, medications, ways to get people to goal with chronic illness. Now we have a lot more tools at our disposal, and so it's possible to get 80–90% of our patients under control for hypertension and get 50% of our patients meeting diabetic metrics. So setting that vision that there is always opportunity for improvement. And so then what do we need to do to generate that improvement? And that's where the standard work and focus on process and, that has led us down the path of this lean transformation in order to continue continuous improvement.
So you talked earlier about IHI, the model for improvement, a shift to focusing on management system. My impression, and correct me if I'm wrong in this, but my impression of the model for improvement is that it's very based on projects, teams, people doing the work. There's a lot of strengths to it. But Is it fair to say that that had been project focused and then you sort of evolved past that?
Yes, that was very much. And if you think about, the work we did originally around access, that we had some diabetes efforts underway, they were very project focused. And the one thing that we lacked that made it challenging to sustain that work is we did not have a way to continuously improve that work. So you would go in, you'd make some changes, use a PDSA approach, and achieve really, as Liz said, fairly remarkable results. But over time, unless you have a system of continuous improvement and a management system to support that, they're really not sustainable. And that, I think, if I look back now, that's what we were lacking and what we're trying to develop and embed in the organization now.
And before diving more into the management system, I'm curious, just for a little bit more of context, if either or both of you would want to comment on what I hear you describing earlier was building teamwork and collaboration across primary care sites, of looking beyond your office and looking to collaborate, and then maybe even more broadly through some of these collaboratives. Can you speak to the power of comparing notes across sites and what that led to before even thinking maybe that's part of the standard work story, but how did that collaboration and teamwork across sites get encouraged?
Well, I can remember clearly, and it was fascinating to see when we did this work, and it seems like a while ago, but it's hard to tell now. When we got frontline teams engaged in making changes and improvements at their practices, they just lit up. It was fascinating to see that. And they would share ideas across these practices. We'd have these learning collaboratives where different practices would get together and present their work. And it was the frontline, primarily the frontline staff. Physicians were engaged as well, but it was so fascinating to see the engagement of these frontline medical assistants, nurses, practice leaders, just embraced this work and came up with some great stuff. I don't know. Liz can comment on that as well, but it was pretty fascinating to see and very powerful.
I think that I think it also was easier to make the appeal because we learned about the power of data. So we tried to be data driven, and that would be somewhat hard to argue with. So I think that helped some of the folks who may have been more resistant to learning from others, because we were able to quantify the impact. And it also just took a little bit of leadership and setting the expectation.
And imagine part of that expectation was trying to define standard work, standard processes. Can you share a little bit more about that process for even deciding where to start of all the different workflows and things that are happening within the primary care setting? Where do you start?
Well, we had a brilliant mind among us in Heather Marsteller, and we learned about value stream mapping. So we value stream mapped a patient visit from beginning to end, and included all of the indirect work, and had to make conscious or deliberate decisions about scope, and what aspects were we going to focus on. Am I recalling that correctly, Dr. Anderson? And I think that what rose to the top, particularly post-Epic conversion, was the burden that our providers had absorbed in those in the workflows during the face-to-face visit, and we didn't know if that was the most efficient, effective way to do things that delivered the best value and eliminated waste. So that's what we focused on initially, where the work.
Level loading the work.
Level loading the work, yes.
And did that level loading come from like looking at scheduled templates during the day and doing a better job of spacing out patient arrivals, or what else did you do to level load?
It mainly came from, as Liz said, doing these kind of understanding the workflow, and you could quantify who spent time doing what. And it became very clear that our providers were taking on a lot of the work that could actually be shifted to our clinical staff. And when you map that out and looked at where people were spending their time and what tasks they were performing, we could shift some of that work to our staff and free up some of the provider time. It also, the other key thing was that, again, in setting that standard work and reducing variability, you don't miss things. So we were able to get health maintenance interventions done. We were get medications refilled. You build that into standard work, and all of a sudden you're making sure important things are getting done.
It was interesting too, because we surveyed staff and providers before we started the work, and our staff felt like their skills were underutilized and they wanted to do more, and the providers felt that the staff their skills were probably underutilized as well. So, and again, it was the process redesign, or the standard work development, was a collaborative, team-based effort. So there was a lot of joy in it. And it's interesting, I think initially there was some resistance to standard work, but we were over time able to demonstrate the value of reduction of that variation. As Dr. Anderson mentioned, it's also been very useful because subsequent to that, our network went through a significant growth phase. And we found that providers came to us with the expectation that we had standard work. Like, how do you do things at Duke? You must do things well. Duke. How do you do things at Duke? And so it was very helpful to be able to set practices up for success from the get-go with our work.
So maybe we can take a bit of a deeper dive now into the shift into focusing on management system. And what was the inspiration or the eye-opening? Was it a moment? Was it just kind of over time, recognizing, as you described earlier, a lack of standard work for leadership as being one driver for it? What else led to that shift?
I think it was, we were challenged to sustain. So we were challenged to sustain. Also, we, as I said, we're going through a significant growth phase. And so many of our leaders had not had exposure or training in lean prior to joining us. And so what we found was that the leadership was doing their very best, but there was really a lack of consistency in their focus and in how they prioritized work. And so that led us to understand and do more learning about a tiered huddle system and standard work for leadership, so that we had some consistency in what people were thinking about and focusing on every day, every week. What was our escalation process, so that we could help eliminate barriers and create a help chain. And what else am I missing?
Well, and it was also the way, once you establish standard work, that's not the end of the deal. You're always looking to improve, and you could use that as a tool, but your goal is how do we make this better? How do we reach these targets? And in order to do that, I think we learned that you have to manage that. It requires leadership, it requires management. And so to make sure that we were all, on the same page from a management standpoint, and we had a process, as Liz said, to escalate issues that needed to be solved. And the other thing that I think we realized is that it allows you to make, once you have a management system in place, you can do things actually much quicker. Like it streamlines the process for making decisions, solving problems, getting improvement work done. That works much easier when you do have a management system in place.
Mm-hmm. So John, you had mentioned earlier about the goal of creating a culture of quality, a culture of improvement. What were some of the continuous improvement methods or practices that leadership would use with staff to help with continued PDSA?
Well, we had a very, as Liz said, we were able to build, I think, good data systems so we could track. So in order, you want to be able to make changes that result in improvement, and you want to be able to measure those changes to demonstrate that you're making improvements. So we were able to put those systems in place, share that data with providers. We became very transparent with our data and shared that across the network as to how we were doing and what our targets were. We also built some of these metrics and improvement goals into our compensation system for providers. So that certainly helped to get some attention. But I think people also took great pride in the fact that we were reaching these targets. We had this focus, and that it informed the care we were able to deliver. And I think that gave people a sense of pride in being in part of this work.
And Liz, how has A3 problem solving been incorporated into the daily management system for problem solving, for continuous improvement?
Well, it's the it's so I think the A3 thinking is the foundation, or it is our the thought process that we try to teach and reinforce as in, for example, in morning huddle, as problems or issues are escalated. There's an assignment, or someone will take that problem and or the team will design a PDSA around that. It's really and it's an opportunity to reinforce the A3 thinking. So let's be clear about what problem we're trying to solve. Let's fully understand our current state. What are some countermeasures? What are our gaps? What are some countermeasures that we could have tried to solve this problem to root? And it is, the vision was that we would be a network of problem solvers, and how do we? So we've tried to focus on how do we develop that coaching skill in our leaders. We're still on that journey. We've asked, but there's a learning curve, and so some folks are at the point where they're still, learning about A3 thinking and how every time you're presented with a problem, how can you apply it every time, or an opportunity every time. We're trying to get our folks that are a little farther along down this path to be doing strategic A3s for their practice. So what's the current state of the practice health in totality, and what are the baby A3s that might come from that? So
yeah, I think we've used it both in local problem solving and as we think of bigger strategic network initiatives to bring that A3 thinking to our larger problems, and it gives us a nice, a useful framework to think about. Okay, how do we, work on access? How do we work on HCC coding and apply that A3 thinking to those big rocks we're trying to move, in addition to the smaller pebbles?
So you talk about that learning curve, and on that topic, tell us about the Lean Mentor program that you have. I think that seems like an interesting approach for how to help people in that learning curve, in their development. Can you tell us, how that got started, how that works?
So I think we came, it was both expedient and necessary, and I expect we're not really very different from other organizations. We have a dedicated performance excellence team that houses our lean management system, but that's a small team. And for a while, we were trying to deploy them to help with this improvement event and to help get this A3 off the ground, and very quickly realized they don't have the capacity or the bandwidth to do that. And in fact, it has been our goal as an organization that all of our leaders, especially our regional middle management leaders, have the ability to coach and work with local practice leaders to develop A3s and build that capability. And so in order to get everybody up to speed as a coach and a facilitator, we developed a program of training and mentoring so that we can basically leverage the capacity of our performance excellence team to train our leaders that can then mentor each other and spread that work and capability. So it's not just relying on our performance excellence team, but frankly, it's a skill that every leader in the organization possesses. that accurate?
Yeah. Great description.
Yeah. One other element of the daily management system I thought we could explore a little bit more deeply is the huddles. You describe morning huddles, tiered huddles. Can you sort of walk through an example of what that daily rhythm is at different levels?
Go ahead.
Well, so each practice has a huddle board with visual management tools on the board, and practices will convene in the morning for 10, 15 minutes prior to the start of the day. And it's an opportunity to both celebrate successes. What are we doing well? What great is going on? It's an opportunity to focus on operational readiness for the day, but then it's also an opportunity, okay, what are we working on? What problems are we trying to solve? People will submit ideas or issues, problems at the practice level, and get those up on the board so we can explore those. One of the challenges we had during COVID is that the huddles spent a fair amount of time, I would say the majority of their time, on operational issues, just dealing with the pandemic. Mm-hmm. And so we've had to kind of migrate back towards an improvement focus, not just an operational readiness focus. And then those daily management huddles, if there are issues that come up, they get escalated through our tiered management system.
And how many tiers are there within Duke Primary Care?
4.
So
in addition to the daily huddles that are with the full practice, the clinic leadership team has a daily vitals session where they have a standing agenda. They have standard work with topics that they cover, any safety issues from the prior day, any staffing, personnel, other sorts of what improvement work is happening, and anything to be escalated. And then, so that occurs on a daily basis. Any escalations can happen immediately to their regional team. But the clinic leader has a standing weekly vital report with the regional team leader. And again, report out on any safety issues, improvement work, personnel issues, and escalations. The regional teams have weekly vitals then with their AVP of operations, and I have weekly vitals with the AVP myself. We also have, and Dr. Anderson has a similar parallel tiered system with the clinical leadership. Mm-hmm. But weekly we have what we call Tier 4 huddle, which is where all the teams come together, the regional teams, the AVPs, also the leaders of our ancillary, what I call our ancillary support departments, so human resources, finance, performance excellence team, our pop health group. And there's an opportunity for recognition, report out on any safety concerns or incidents. It's a red, green, yellow report out from each regional team and the ancillary departments, and then we discuss any escalations and have report out on follow up on any prior escalations from prior weeks.
Before we wrap up, I wanted to close the loop back to a mention earlier of a story that you have, John, about the impressive results on waiting time. Do you want to go ahead and share that?
Well, I think a couple things come to mind. Early on when we started this work, as Liz said, we had, wait times of 3-4 months, even longer for our annual physicals. And we made one simple intervention. Back then, we had all kinds of appointment types that were set up by disease state and problem oriented. If you have this, you need this kind of appointment, and just a myriad of appointment types. And we made all that go away and standardized our appointment types, and immediately our access improved. I mean, it was fairly dramatic how that happened. I think now the stories I would tell are a little more challenging. We're in a part of the country that's experiencing tremendous growth. The health system has grown. The demand for our services is escalating, and providers are struggling, feeling burned out. And so, we're working on access again. But the stories I would tell are patients like to come see us. They like to come see us in person. And they want to be able to see us when they have a need. And I've had a couple of experiences lately with patients that were able to get in, not typically my patients, but patients of the practice. And they both ended up with very serious health issues that lended themselves well to being in a primary care practice, not the ER. And we were able to get those patients into treatment. So it certainly reminds me of how critical it is that we do provide care to patients when they want it and on their terms rather than our terms.
Mm-hmm.
It's such a critical way to think about it, I think.
Yeah. Well, thanks to you both for sharing, the story, the transformation. Like you said, it's never ending, but I'm glad that the leadership and the energy to keep that going is there and is clear to us, I think, as people who are hearing your story today. So our guests again today have been Dr. John Anderson, Chief Medical Officer at Duke Primary Care, which is part of Duke University Health System, and Elizabeth Long, the Chief Operating Officer. Really want to thank you both for taking the time and sharing so much with us today.
Thank you, Mark.
Thank you, Mark, for having us. We've enjoyed the conversation.